Wanted to give just a brief introduction for Dr. Knight. She's worked with CDC for the past 10 years and currently serves as a director of the Division of Global Health Protection, or GDHP. Previously, Dr. Knight was a country director for CDC South Africa from July 2012 to April of 2017. Prior to her arrival in South Africa, Dr. Knight served as a director of CDC's Division of Global HIV and TB in Kenya, and as CDC's Assistant Director for the Clinical Program for PEPFAR, and then as CDC Country Director in Nigeria, where she also provided medical care to the mission community at the Embassy Health Unit in Abuja. She provided oversight and direction to the interagency PEPFAR program in each of these countries, responsible for the effective planning of approximately $450 to $500 million annually. Throughout her international career, Dr. Knight has led the development, coordination, implementation of key public health policies and programs. She has extensive experience advancing public health priorities through leadership and close collaboration with government officials and partners. Dr. Knight began her career with the U.S. government in HRSA's Bureau of Health Professions in 2001, serving in several different roles, including branch chief of the Primary Care Medical Education Branch, Division of Medicine and Dentistry, and acting deputy director, Division of Medicine and Dentistry. Her work in the division focused on improving the quality of primary care medical education services in the U.S. and include management of a budget of roughly $93 million and more than 450 grants annually. She's also supported public health at the local the local government level with the City of Cincinnati Health Department, providing primary health care services and working on a number of response teams responsible for local and regional disaster response and coordination. Dr. Knight received her Bachelor's of Arts in Biology and Psychology from Washington University and her medical degree from the University of North Carolina at Chapel Hill, where she graduated with honors. She completed her family medicine residency at the University of Cincinnati and is board certified in family medicine. I think this is my favorite tidbit about you, and so excited to have you here as well to present on some very fantastic work. But prior to medical school, Dr. Knight served as a Peace Corps volunteer in Lesotho, where she worked as a secondary school science teacher. So near and dear to our hearts here at Georgetown. Thank you so much for being here, and welcome.
Thank you. Thank you so much for having me. I've been really looking forward to getting a chance coming to meet with you and talk with you about global health security, and specifically diving in a little bit on some of the work that CDC is doing internationally. So some of the things that we're going to touch on today will focus around what some of the challenges are that we're facing in global health security, how CDC has been working internationally, and not just within the realm of global health security, but prior to the global health security agenda. What are some of the accomplishments that we've been able to have so far, and where we'll dive into a few examples in a few different countries, and then also talk about some of the remaining challenges and then opportunities where others, I think, can still focus on engagement within global health security. So first, we'll touch on some of the challenges. I think one thing that is certainly a benefit to all of us is the increased ability to be able to move much more quickly and rapidly around the world, but that also means that pathogens can move much more quickly around the world as well. And a pathogen or an outbreak that is in any remote village on any of the continents can move to all 6 continents, to a major city on all 6 continents within as little as 36 hours. So certainly mobility played a large role of the Ebola outbreak in West Africa, and has the potential to play a large role in many other outbreaks. So this is just a reminder that we have historically faced a number of public health threats, and that they can come from a variety of different realms. So, for example, HIV is something that went undetected for a number of years before we really were able to identify that this was a new pathogen that was causing disease, and then determine what it was. So as we talk about global health security and some of the systems that countries are working on improving for their own protection of their own people and protection of those around them, think about what could have been in terms of the direction of the HIV epidemic if some of these countries had these systems in place at the beginning of the epidemic. We also have to recognize that there are a lot of diseases like avian flu that are zoonotic diseases that cause significant impact on the animal population and are transmitted to humans and cause some significant impact on the human population. So one thing that I think has been a greater focus under the global health security agenda has been trying to bring together these different sectors within a country. You know, having worked overseas for a number of years on the human health side of things, I can say that there's often a lot of good work that's happening in the different sectors, but the coming together has been a challenge. So that's where GHSA really tries to bring those things together. Then, of course, we have things like antimicrobial resistance. TB is a really good example, or I guess a really bad example, of antimicrobial resistance with MDR TB and XDR TB. And then we have things like anthrax, so use of pathogens for untoward purposes, right? Where like the anthrax release that occurred not far from here, just really only a few years ago. SARS is another good example, as well as Ebola and Zika, of how pathogens can move very quickly. SARS in just 4 months impacted 37 countries on 3 continents before that outbreak was contained. So there are always public health threats that are being faced in individual countries and that have the risk of spreading across borders. So another thing that we know as well, which put together with the risk of the pathogens, the ones that we know about, as well as new pathogens that we're still discovering, put that together with the fact that most countries are not prepared. Self-assessments done by countries, only 1 in 3 reported that they were fully prepared for outbreaks. So that really has brought us to the realm of global health security. As countries were doing their self-assessments and continuously not being prepared, and we were facing outbreaks like the SARS outbreak, WHO and other countries, member nations of WHO, really looked to, what can we do to help move forward the agenda? And the international health regulations were developed, but countries still did not achieve the international health regulations. So then in 2014 was when the Global Health Security Agenda was launched in February of 2014 to try to help countries to come together and to develop standardized metrics and standardized processes for trying to walk them through the development of their international health regulations, or the achievement of the international health regulations. Another thing that is really important with global health security is the economic impact. So the health impact may be quite obvious of disease, right? You have morbidity and you have mortality on humans as well as on animal populations of diseases. But there can be a tremendous economic impact as well. So SARS, for example, in those 4 months and then the ensuing aftermath on the economy cost $40 billion. Ebola cost $30 billion globally. In those 3 primarily affected countries that are low-income countries, their impact was in the millions. So significant financial impact, which can also have significant impact in the United States, even if the outbreak or the disease doesn't reach the United States. And so one thing that we have done is looked at across a subset of countries, 49 countries, where we have been focusing our work. We've looked at how many, what are the companies that are exporting goods or services to those countries, and how much is that portfolio of exported goods worth? And then how many jobs could that potentially impact in the United States? So on an annual basis, the US exports across basically every state $308 billion worth of goods just to these 49 countries. And that helps to support 1.6 million jobs across the United States. And this is from, when we were looking at this data, this is data that we've gotten from publicly available data sets from Department of Commerce. And then we looked at, well, what if we take a specific country? Let's model what could be the impact of an outbreak in a specific country on the United States. So let's just take one country in Asia. If they had an outbreak just within their borders, it could still impact almost 1,500 jobs and almost $64 million worth of export goods from the United States. If that then started to spread, so think about Asia, and this is a Southeast Asia to the Asian continent model that we did, where there's high risk of pandemic flu. So start off in one country, that could be the impact, and then as it spreads to the region, to 5 additional countries, it could potentially impact more than 254,000 jobs and $7.9 billion of export. And then to the continent, much, much more, especially with China included within that, at 1.37 million jobs and $41.4 billion worth of goods. So we often don't think of the impact on other sectors of a public health event, but it is important and touches upon many sectors that you would not traditionally consider relevant within an outbreak. And then we've also started to take this and look at it related to each state. And again, using publicly available data sets on commerce, trade, and travel and tourism. So if you think about Virginia, for example, Virginia has more than 78,000 jobs that are supported by companies that have exports to other countries. If you think about the impact of potentially bringing, as I mentioned earlier, the 36 hours for disease to travel, there's a lot of movement of people in and out of Virginia as well. More than 45,000 travelers to Virginia from other countries in 2015, and almost 1 million Virginia residents that traveled internationally in 2015. And then, of course, one sector which is often highlighted when you talk about zoonotic diseases is the poultry sector in agriculture. And avian influenza, like the H7N9 outbreak that we've had this past year, could potentially impact Virginia if it were to reach Virginia. Virginia has 269 million broiler chickens that were produced in 2016 at a value of $733 million. So we're not talking like small figures when it comes to the potential impact on the economy of the United States or the economy of a single state. So now I want to shift gears and talk a little bit about CDC's history and how CDC became involved in global health. So CDC, about 12 years after we were formed as an agency, and CDC was actually formed, we are based in Atlanta, and we are there because when CDC was started as an agency, it was focused on malaria control. That was the only focus. It was just one disease, one communicable disease, and now we've really grown to an agency that focuses on public health broadly, communicable and non-communicable diseases. So CDC first became involved in global work in 1958 in smallpox and cholera. And then since then, CDC has really expanded its portfolio. Probably one of the largest expansions of the portfolio has been the HIV/AIDS program. We were chatting earlier before the session started. The Division of Global HIV and TB, which is one of the divisions that I've worked for previously, is CDC's arm of the U.S. government's President's Emergency Plan for AIDS Relief. So with the PEPFAR program and the large investment from the U.S. government into the PEPFAR program, that allowed CDC to expand our reach to a number of other countries where we had not previously been. We've also been involved in the SARS outbreak, in novel pandemic influenza, in the President's Malaria Initiative in conjunction with USAID, and in global health security, global disease detection and global health security. And most recently, of course, outbreaks that we've been significantly involved in was the Ebola outbreak, where CDC, we've had our Emergency Operations Center in Atlanta activated for the Ebola outbreak, as well as for the Zika outbreak that is continuing. So CDC's global presence is quite large. We have more than 1,700 staff that are comprised of both our American staff, our U.S. Citizen staff that are deployed overseas, together with local staff, individuals from those countries who we hire that work in our offices. And we do work in more than 120 countries, many of those with staff on the ground in those countries, and some of them where we are collaborating and implementing projects with the host country governments, but not necessarily with an office. So CDC is divided up amongst a variety of centers. One of those centers is the Center for Global Health. And the Center for Global Health is actually a relatively new center, even though CDC has had this extensive history of global work. It's been implemented through a lot of the other centers across the agency where maybe those diseases sit. So the Center for Global Health was formed out of what used to be our coordinating office for global health, and was formed in, now I'm going to forget, I think it was around 2010 when it was formed. And it brought together some of the other previously existing divisions, the Division of Global HIV and TB that I mentioned, the Division of Parasitic Diseases and Malaria, which deals with our President's Malaria Initiative and neglected tropical diseases, and the Global Immunization Division, which is home to our leadership for the Global Polio Eradication Initiative, as well as other vaccine preventable diseases. And then the the Division of Global Health Protection, which is my division. This division is actually even younger, was just formed a few years ago, and was formed from a few divisions and programs that sat in other parts of CDC. So this is just a bit of our portfolio in the Division of Global Health Protection. We were talking earlier about the EIS program, that's CDC's Epidemic Intelligence Service program. So we have the Field Epidemiology Training Program, which is modeled on the EIS program, and has a 2-year training program. We established those with ministries of health and help them to, we provide mentorship, we provide a resident advisor, and help them to get residents through that program and eventually to take over the leadership and the running of that program themselves. So in addition to the 2-year program, we also have established what's called our Frontline program, which is a 3-month, more intensive program and meant more for healthcare workers, public health workers that sit more at a district level in a country. And this was something that we really ramped up with the Ebola outbreak, when we really saw that there was not the level of expertise that was needed out at the district and community level to be able to really identify a outbreak within the community and determine how to investigate that and how to deal with it. So that Frontline program has really been quite successful, and in a number of countries, and I'll highlight that in some of the country case examples that we'll go through. Our Global Rapid Response Team is a headquarters asset that helps us as an agency to be able to augment outbreak responses in other countries. And this was also something that we developed following on lessons learned from the Ebola outbreak. CDC needed to deploy such large numbers of people for the Ebola outbreak that it actually became challenging for us as an agency to be able to identify who are the right people across the agency with the right skills and that have the right kind of administrative things that you need as a US government employee to deploy. You know, who has a passport, an official passport to be able to deploy, who has had the required US government trainings. Everybody has required trainings, right? So before we can go to another country, we have to have certain trainings. And so we needed to put a system in place to know who are our people, what are their skills, and are they prepared? Do they have all of those administrative requirements to deploy? We also work with countries on their national public health institutes. So that is their CDCs. And we've helped many countries to establish their own public health institutes. We have, I'm going to skip over to the global disease detection. That's something else that we have at headquarters. It's an electronic event-based monitoring system. So we have analysts that are receiving data and analyzing that data on a daily basis. It's pulled from newspapers and electronic sources from around the world and helps us to identify outbreaks that are occurring. Not necessarily things that we need to react to or respond to, but just to be aware of and to verify. And then we also have a small communicable or non-communicable diseases portfolio that focuses primarily on cardiovascular disease, but then at times has done a few other things like road traffic injuries and stroke prevention. And we'll talk more about global health security agenda and joint external evaluations. So through those programs, some of the things that we've achieved so far, that operations center, that electronic surveillance system, through that we track and monitor about 30 to 40 outbreaks every day. Now some of those are the same outbreak that you identify and then you continue to track it, and then some of them are new outbreaks that we see occurring. Through the field epidemiology training program, we have now trained, this says more than 10,000, we're actually up above 11,000 people who have been trained now globally since the initiation of that program. We also have certain country offices are identified as our regional global disease detection centers, and those offices working in counterpart with the ministries of health are doing things like new pathogen surveillance systems to look for new pathogens. Or I should say new microbes, because you don't necessarily know if they're pathogenic to start with. They also help countries to introduce new diagnostic tests into countries that they had not been using previously, so to improve their own capacity on the laboratory side to do diagnostics. And then, as I mentioned, the Global Rapid Response Team, we now have more than 400 people who are rostered from across the agency on that team who we deploy for outbreaks. Now, with the Global Health Security Agenda, there are more than 60 countries, including the United States, that has signed on to GHSA. So through that framework, we work with those other countries. And one thing that we have helped to support together with other countries is the provision of external expertise on the joint external evaluations. So these are the standardized external way to go into a country and to score a country on their preparedness, on the different components that they need to have in place to achieve IHR. And we've provided expertise to about 60% of the 72 JEEs that have been completed to date. Across the US government, there are 17 countries that we committed to under the previous administration at the start of GHSA. So with those resources that Congress gave us, which was about $600 million for Global Health Security Agenda, we committed to using those resources and focusing intensively on 17 countries. We call those the phase 1 countries. So what we do is we track through our country offices that are there working with the governments. We will track the progress on achieving certain components of the of the joint external evaluation under the lanes of prevention, detection, and response. So this just kind of gives you an idea. This is our recent data. Now this is not from a repeat joint external evaluation. So countries have a baseline JEE, and then what we ask our country offices to do is to look at what's the progress that's been made in the past year, and where would they, if they were scoring them, where would they score them? What would they say that they have achieved? So through that, you can see we've helped countries to enhance their surveillance systems for zoonotic diseases. We've helped countries to detect dangerous pathogens using new diagnostic capacities, like I mentioned, and we've helped them to establish their emergency operations centers. Now, that doesn't mean that each of these things is working perfectly, or that it's working independently, kind of on its own, without our help or without the help of others. But it is a progression that countries have been making. So this is also data just from 2017 to kind of summarize some of the key things that we've seen in the last year. Those 30 to 40 outbreaks per day resulted in 337 unique outbreaks that were tracked. Through the on-the-ground assets of the Global Disease Detection Centers, we supported 198 outbreaks where they needed us to help augment them. Through the field epidemiology training program, so those government-owned programs that we manage with them, they had fellows that investigated 571 outbreaks. So these would be outbreaks occurring in the countries that may or may not have been picked up through an electronic surveillance system. Some of them could be just within one small community, and often are. And our global rapid response team, last year we had almost 9,000 person days on the ground across the world in deployment. So then, as I mentioned, also the joint external evaluations. This is part of our multilateral work with WHO and others. We are up to 72. It seems like every week there is another, one or two that get completed. There are 29 more that are planned, currently scheduled for this year. And this continues to be a significant focus of WHO, as well as the next step, which is really helping those countries then to develop their national action plans. So to take their results, to look at the gaps that were identified, prioritize them, and put in place a national action plan. So now I want to touch on a few different specific country examples. The first one is from Liberia. And for those of you at the back of the room, I don't know if you can read what's in every box, but basically the top line is from the Ebola response. So 2014 Ebola response, and the timeline there is really in months. And just to show how long it took, more than 90 days for Liberia to even begin the outbreak, the detection of the outbreak and response, and then not until 2016 when Liberia was declared Ebola-free. Compare that to this past year in April, end of April and early May. There was, on April 23rd, there was a patient that died after attending a funeral in Senegal County. So right after that, within 2 days, those FETP frontline graduates, those district-based frontline staff, they were deployed and they were able to get to the county to start the investigation. There were a total of 18 cases and 10 deaths unexplained associated with the funeral at that time. They then activated their emergency operations center. Specimens were collected. They were, because of the laboratory testing capacity that we had helped to develop, they were able to test them and determine that they were not Ebola. And then further laboratory testing was done through CDC to ultimately determine that this was an outbreak of meningitis. And it was contained in the end with a total case count of 31 cases and 13 deaths. And this happened, by the way, right before our Secretary for Health and Human Services was scheduled to go to Liberia. So we were faced not only with an outbreak, which, of course, in Liberia, with it being associated with the funeral, everyone was really concerned about Ebola. And on the political side of things, we were trying to determine, can we send the secretary there? So this rapid response allowed them to identify it, to determine the pathogen, and to contain it. Here's another example. This is from Sierra Leone. So in Sierra Leone, rubella is not a reportable disease within their IDSR. So they were finding that they were having a number of children who were presenting with what they thought was measles, being tested for measles, but laboratory testing was negative for measles. So they implemented a program to ensure that if they were tested for measles and it was negative, they should be tested for rubella. And our one of the trained field epidemiology residents started looking at the laboratory data and really was able to demonstrate that a significant percentage of these children did have rubella. Rubella is not part of their EPI program, of their routine vaccinations. So they were able to use that data to advocate for the inclusion of rubella vaccine as a routine vaccine for the children. So it has not only implications on the potential outbreak, but how do we use some of that data to change policy to look at gaps in policies in public health?
Did that create a market for MMR vaccines?
I'm not sure.
Okay.
So a lot of countries with their EPI program, they will get their vaccines through like WHO and Gavi. So I'm not sure what they did in terms of the introduction of which vaccine. This is another example. This is from Uganda and Kenya. And it always seems like outbreaks occur right before like political bigwigs are supposed to be coming to a country, because this example from Uganda and Marburg was right before the Global Health Security Agenda ministerial meeting, when ministers of health and other ministers were all traveling to Uganda for the annual meeting. In this example, the part I really wanted to highlight, so the Marburg outbreak was contained very rapidly, but what I really wanted to highlight here is that there was actually cross-border coordination that needed to occur as well. So in Uganda, through the work that CDC had been doing with them to strengthen their surveillance system, through the field epidemiology training program, they were able to identify the death. Because we had strengthened the laboratory system, or sorry, not the death, the case, we were able to, because we strengthened the laboratory system, they were able to diagnose. And because we had strengthened and created an emergency operations center, they were able to activate that. So through the Ugandan government and the CDC office there, and the trained disease detectives, the field epidemiologists, they were able to identify the movement that this individual had made across the border to contact the Kenyan government officials on the other side of the border, the CDC office in Kenya, and the field epidemiology program in Kenya, to make sure that they deployed their disease detectives, their field epidemiologists, to do the investigations here. And went to where he had gone to visit his family and where he had sought care with a traditional healer, and make sure that the individuals that he had come in contact with were tested. And then this is an example from Senegal. Last year, Senegal had an outbreak of H1N1 pandemic flu. So WHO has called a PHEC, a public health emergency of international concern, 4 times, one of which was for pandemic flu. But not this time, because this time it was contained very rapidly. They had children, they had reports of children that were ill and dying in one specific district. So they activated the EOC that we had helped to establish. They deployed some of those disease detectives, the frontline FETPs, and they were able to go out, do the field investigation, and determine that it was H1N1 pandemic flu. And they were able to contain this in just 11 days with 118 cases and 3 deaths through education, control measures, and messaging. And then in Pakistan, some of the health security strengthening work that we've been doing there has really helped them to identify more outbreaks. This is where we've also trained frontline field epidemiologists. And so now that they have more individuals across the country that are able to identify when an outbreak is occurring, they're detecting more of them. They've also detected that many of those outbreaks are due to diseases that are vaccine preventable, where immunization programs just have not been reaching them. So this has also allowed them to utilize some of their own resources. Again, not everything is done by us or funded by the US government, so they've used their own resources from the local health departments to conduct those investigations and to provide some vaccine campaigns that resulted in more than 46,000 children receiving vaccinations to help to prevent more of these vaccine preventable disease outbreaks. And then the last country example I wanted to touch on is in a different realm of health security, which is biosafety and biosecurity. So as we help to establish the diagnostic skills and the laboratories, we also have to recognize that the reason we're setting these up is because we want them to be able to detect pathogens, and some of them that can be quite dangerous pathogens. So we have to make sure that they are safe workspaces for the laboratorians, and to ensure that that workspace then is not going to only, make sure that they're not going to get ill themselves, but also then not spread those pathogens. So one important aspect of this is really the biosafety cabinets, which require a very specific certification process on an annual basis. And a lot of times, we'll bring equipment into countries, but then how do you inspect it? The inspectors are international inspectors. It's very expensive for them to be able to keep the equipment up and maintain it because it requires this international presence. So one thing we've done in many countries is worked to train local inspectors so that they then are there as the workforce on the ground to ensure the safety of the biosecurity cabinets. So then the last thing to touch on are some of the existing challenges and where those challenges also present opportunities. I think first just to remind ourselves that this is often what we see. Freak out, lots of panic, lots of action, and then everybody calms down and gets busy and focuses on other things. So how do we keep this from happening? And then what are some of the barriers that we face? I've talked a lot about our support as the US government and through CDC, the work that we've been doing, but there are a lot of other stakeholders out there. We have many other countries that have made commitments to the global health security agenda. There are many other countries that have followed through with those commitments, but how do we bring more to the table? How do we get more countries involved? How do we get more NGOs involved? How do we get more private sector involved? In order to help to move forward with more involvement, information is needed, data is needed. Other countries, businesses, NGOs all need to know, well, what are the gaps and what's my added value? How can I fit in? So information has to be shared, which is sometimes a challenge. There's also risks in terms of having poor quality assessments. That's where I think the JEEs have been extremely helpful to identify those risks, but not all countries have those yet. We also need to have accountability and transparency. on how much are the host governments themselves investing, what are they putting forward, as well as what are we putting forward. And as always, funding is unpredictable and insufficient. But putting those resources up front is certainly much more cost effective than having to, than waiting for an outbreak to occur when it's going to cost us a lot more to contain it. So really some of the key things in moving forward are, as I mentioned, these partnerships and expanding partnerships, making sure that other sectors that have started to engage in global health security are really much more actively engaged in global health security, which as more partners become involved, that requires a lot more coordination. It requires more consolidation of the work that we're doing. And of course, as all this is happening, we have to maintain that constant monitoring. We still have to keep our eye on what is happening on a daily basis. So as we build global health capacities, we help to prevent the spread of diseases that impacts health of humans, that impacts health of animals, and gives us that greater stability, economic stability within those countries as well as globally. So then a few more things about what you can do. First of all is, continue to educate yourselves. There's lots of information that is out there now. You can find the JEEs are online. Not all of them are online yet, but as they get completed and then kind of go through the editing process, WHO posts them online. So those are available for you to see, especially if you're interested in working in a specific country. We're also trying to publish as much as we can about what we're doing and the lessons that we've learned. And this is in things like the US government has a Global Health Security Agenda annual report, and we at CDC just had a supplement to the Journal of Emerging Infectious Diseases that was completely focused on global health security. And the two, those economic examples I was giving you are two articles that we've published in the Health Security Journal. So ways in which you can help to advance global health security is through the science. We need to build the evidence, we need to use the data, characterize the threats, look at the best practices for implementation so that other countries can learn from one another and determine what is the impact of those best practices. Collaboration across sectors and across different partners, and amplify, get the message out, continue to move the message forward. We also have on our website, so under the CDC's Division of Global Health Protection, a variety of social media messages and infographics that help us to get the message out and that partners can use to get the message out as well. And then here are a few links to our website and our contact information. So thank you.
So,
Questions?
if anyone has any questions, yes, please either raise your hand or just go for it.
Or comments or ideas, not just questions.
Dr. Knight, if I can ask, one of the things I think we struggle with in terms of thinking about how we can build health capacity across the globe, not only at home but overseas, is thinking about when you are effective in disease detection and response, it does not get publicized. There's no there.
Mm-hmm.
And so how would you suggest, or in your experience, what are some ways to promote successes of building up the capacity so that you detect quickly, respond effectively, and contain before it becomes a potential fear?
Right. No, that's a great question. I mean, that's the rub. When we're doing a great job, nothing happens.
Right.
Everything is calm and quiet. So that's one way in which we are really trying to get information from like I talked about, the information sharing, to get information from our CDC country offices that are working in collaboration with the ministries of health and from the ministries of health themselves to share and let us know how often they have deployed those FETP graduates, so that, how many outbreaks have they responded to, and what were some of those diseases that they responded to. That's the kind of data that from a country level can be very helpful for us to then say, okay, within this country, they were now able to successfully contain X number of outbreaks across the constellation of these diseases, and in a response time that averaged, X number of hours or days. So we are getting that kind of information, but it's not something that countries have been used to tracking. So that's one of the things that we have been working on, is looking at what are some of the indicators that we need to have to help to show the success of the programs. So some things are more outputs, what are some of the number of people trained and things like that, but ultimately then how do we measure some of those outcomes? Yes.
I have a question, sorry, apologies for the diva entrance. So a question about the number of deployments that you showed, which it's great that you're capturing the number of people who are on a ready roster. I think that's a huge step forward.
Mm-hmm.
But with that roughly 9,000 person days a year, that's like, based on crude math, like 26 people abroad on any given day on average. What do you see? I mean, that's an enormous cost and also an enormous burden on CDC staff.
Mm-hmm.
And as some of the offices that have been supported by GHS funding overseas are shrinking, what do you see happening to that demand for CDC personnel deployed abroad for outbreak investigation and supporting some of the immediate just-in-time training and other activities that help support outbreak investigation on the ground? So where is that going to go in the next years?
Right, that's a great question. So as you may have seen, we are going to be getting an increase to our base budget in FY18. Congress added $50 million to our line item, our global disease detection emergency response line item for FY18, and that should be hopefully getting signed today to prevent a government shutdown and then give us some additional resources in this arena. At that level, though, it's still not at the level of what that large supplemental was able to give us. So I do think we'll have the ability to do more in some of the countries that we've been working in than we would have been able to do at that lower level of funding. And for right now, we still have some of that supplemental funds too that countries have that are being expended. So right now, is there a risk of an office closing tomorrow? No. It's going to be more in the next 18 months. And we will be able to, I think, keep a few more of them open. That's what we had hoped would be possible if we were to get additional resources, and that's some of the messaging that we had given too. We would like to stay in a few more countries too. So we'll still have to crunch the numbers on all of that. But at the same time, it's important for us to have, as you said, these headquarters assets too. They are deployed to countries where we have country offices, but also to countries where we do not. Like the plague outbreak in Madagascar. We don't have a country office there per se. So we can deploy them anywhere. And they deploy not only for outbreaks, but also for other public health threats. So actually our largest deployment in terms of the cost for the deployment was hurricane related this past year. So we're going to have to continue that asset, most certainly. One of the reasons we've really been focused on the field epidemiology training program is to give countries more of their own ability to respond, so that, ideally, we would get to a point where countries will have a strong enough workforce, have enough people with enough training to be able to do a lot of that response themselves, that we then would not have to have as many people deployed from year to year, depending on size and scope and number of outbreaks. But for now, we're going to certainly need to continue supporting that kind of an effort, because that's the way that it's that partnership that we've been able to have to keep those outbreaks under control. Yes?
My name's Andrew. I'm a first-year med student here at Georgetown. Is there any component of the emergency preparedness framework that focuses on integrating doctors and nurses that want to volunteer but aren't U.S. government employees and would like to go to Sierra Leone? Is there any framework for integrating them into a comprehensive U.S. government response, or is it all ad hoc via NGOs?
That's a good question. So, yeah, people deploy or go to assist in a number of different ways. Certainly, NGOs are one way for individuals to deploy, and I think as countries get stronger emergency operations centers with that incident management system, that will also help any kind of coordination of deployed assets, no matter how they come into a country, to be much stronger and much more effective. So, for example, during the Ebola outbreak, the volunteers that were going to, maybe Liberia or Sierra Leone, before they established any sort of an emergency operations center and incident management system, it was more challenging to coordinate. In Nigeria, where I went for the Ebola response, there was an emergency operations center that was established within the first couple of days of identification of that first case in Lagos. And so all partners, all NGOs, all companies, anybody who had any asset that they wanted to bring to the table for the Ebola response had to come to and through the EOC to talk about, this is what we have, whether it's people or vehicles or whatever kind of asset they had. And then the EOC leadership would determine, is that an asset that we need here or not? Or is it just a distraction? And would say, yes, thank you very much, or would say, no, thank you very much, depending on what they decided. Now, for outbreaks that occur kind of overall, I think one other thing to keep in mind is that WHO also deploys people. There's the Global Alert and Response Network, or GORN, which is also a deployment system. And sometimes we deploy people, CDC people, through WHO, through GORN. So we can deploy them as a CDC, rapid responder, or we can deploy them as a WHO GORN asset too. And that's another way for other individuals with specific technical expertise, doctors, nurses, or others, to be able to be deployed through GORN too. Yes.
Hi, I'm Nathan Woods. I'm with the State Department's biological policy staff. And so I'll ask a scary question, although we've already answered the budget question, so I'm not sure how scary this will be. But those rapid response teams, how are they expected to function with a possible deliberate release?
Well, I think, so with a possible deliberate release, certainly in any country where we deploy people, we work with our State Department colleagues, with the U.S. Embassy on the ground. And even during Ebola, when for the CDC assets that were in the different countries, and I'll speak from my example in Nigeria, when Ebola was in Lagos, we worked very directly with the consulate in Lagos, and they helped provide a lot of the assistance that we needed as U.S. mission personnel on the ground. When Ebola went to, when one Ebola infected individual flew to Port Harcourt, which is in the Niger Delta, so historically a relatively unstable environment, especially for outsiders. So when he moved to Port Harcourt, we worked very closely with the embassies and the consulate's security staff under the Consulate General to make sure that we had all of the assets that we needed to be able to deploy safely in that environment. Now, another thing that we've done is we also have put in place cooperative agreements with several different partners that have expertise that they can lend in an outbreak response to. So the way in which we have those cooperative agreements established is that if there are outbreaks, whether it's intentional or non-intentional, because I think in terms of the public health impact, like we would still need to treat the public health impact and the containment in a certain way. when it's intentional, we would have to do that in conjunction with law enforcement and other other assets too. For our public health part of it that we would be responsible for, we could do that ourselves, as I said, with that assistance from others. And we could also do that through through some of our other partners. So if there are geographic locations that are very difficult for us as the U.S. government to get to, but it's easier for an NGO that already has assets on the ground to be able to get there, we can utilize them to help us. So there are a number of different ways which we can try to work either with the host country governments or with others, and as ourselves in conjunction with State Department and law enforcement officials, if it's in the case, like you said, a deliberate attempt.
Complicates it quite a bit.
Complicates it quite a bit. I mean, certainly it's kind of like in the standard disaster management system, you don't put more people at risk than are already at risk.
Oh, right.
You know, when
you have insurance problems, you have is the country that's donating help saying no, we need to keep it at home now because we might be hit with this disease next? Or I was just wondering if you kind of gamed out some of the things that you're censored.
Maybe not quite to the degree that you're talking about.
So can
Just to quickly toss in, under GHSA, one of the response packages specifically focuses collaboration between law enforcement, clinicians between law enforcement and public health. And
Right.
in several of the GHSA phase 1 countries, and definitely in some of the phase 2 countries, there are ongoing training efforts supported by CDC in an interagency mode to build the capacity of rapid response teams in those countries to work collaboratively across sectors and respond. And I'm sorry to jump in on that, but it's been a very active program, and it's a place where CDC, FBI, BEP at the State Department and CBEP at Georgetown have worked together to really promote that sort of multi-sectoral dialogue. And I think it's never perfect, but it's certainly becoming more robust in a lot of countries.
It is. I mean, I think that cross-sector dialogue overall with GHSA has been tremendously enhanced. You know, whether you're talking the cross-sector dialogue with the law enforcement or the cross-sector dialogue with animal health and agriculture, or even the cross-sector dialogue with ministries of finance. I think, one of the challenges that we often see in some of the core public health programs in the countries where we're working is that the health, the people, those workers in the Department of Health or in the ministries of health, they know exactly, they'll know what their program is doing, they'll know what the gaps are in their program, they'll have ideas of what they need, but they don't know how to translate that into a language that Ministry of Finance speaks. And I think with GHSA and having it purposefully be a cross-sector platform, it brings all of them together to look at this framework in a way that maybe finance and law enforcement and agriculture haven't looked at it before.
And military.
And military, yes.
That's part of the securitization of health has really brought health into the forefront for a lot of militaries through GHSA and has created some buy-in where we wouldn't have seen it before. So GHSA itself, I think, is not worried about the source of the outbreak. The prevent, detect, respond is the same no matter what the source is. So. But you do have this cross-sectoral, multi-sectoral engagement.
Right.
I have a question about data. You mentioned in your first description of the Disease Protection Operations Center that people would look at media reports and things like that. And I'm interested more about routine data that's reported from health workers up through ministries to WHO and then back down, and the ownership of such data. In some sense, I don't want CDC finding about the next outbreak by reading about it in the local paper. I prefer for them to have more timely, more reliable reports, perhaps. So
Sometimes the media can be very tight.
Oh, yeah. Yeah. Tip sheets. But I think a question about how your office or the global health area is dealing with the question of ownership of data and sharing of data.
Mm-hmm.
It's something that we at USAID have looked at and have interesting experiences with.
Mm-hmm.
And perhaps, and honestly, I don't know how I feel about this because I'm not sure that I want my visit to my doctor being reported to WHO routinely.
Mm-hmm.
But so could you speak to that issue?
Sure. So when we look at, maybe I'll talk about it a little bit from like what are some of the data sets, right? So and how do we find out about outbreaks? Because you mentioned the media monitoring. That's one. That electronic monitoring is one type of surveillance system. But then we have the other types of surveillance systems within a country that we're putting in place as well. So those are things from like you mentioned, within a public health system, there are certain reportable diseases, just like we have here in the United States, reportable diseases, that from that health unit down at the local level, up through maybe the district health office or provincial health office to the national, should be getting reported through either a paper or electronic based, or often a combination of paper and electronic based systems. So in many countries like Sierra Leone, for example, they've gone from having a reporting from across the country and all of their sites of, I think it was down in the level of maybe 35% to now more than 90% are reporting on a weekly basis. So that's one way in which information flows. Now that doesn't mean that that's necessarily an outbreak, but that is reportable disease information that's coming in. Not saying this guy came in, but here are the number of cases that we've had this week across this span of diseases. We also have put in place community-based surveillance systems. So like in Vietnam, and we're doing this in other countries like Senegal too, but Vietnam is one I just traveled to, so that's one that's on the forefront of my mind. There's a community-based surveillance system that's been put in place where they have kind of the equivalent of a community health worker at their commune level, which is that smaller community level. And those individuals have certain, they have kind of a checklist of certain things, certain triggers, that if they hear about it or see it within the community, they report it into the health unit. So that's not individuals coming in or an outbreak necessarily that's come to the health unit, but it's a community worker that identifies, this patient has a family member that just died and was otherwise young and healthy. So certain triggers that they then report in. They're not there to diagnose or determine what the problem is, but they'll report it in and then it can be investigated. And that, if it, depending on the level of what they find, may just be something they deal with right there at the clinic, or it may be something that needs to go up in through the, for an emergency operations center activation. But that is linked to the EOCs there. And then we have systems like this electronic surveillance system platform, which we utilize globally. There's actually a newer another electronic surveillance system which is supposed to kind of pull from more sources and I think weed out, I'm not an IT person, so I may not be saying this exactly correctly, but kind of weed out more of the noise that is going to be utilized by WHO, and then to roll that out across member nations. So we're doing those systems in parallel now to kind of compare them, working with WHO, and then that will be something that countries will eventually all have the ability to put in place and to utilize. Some other countries are already doing some other version of electronic surveillance systems now too. So we have a variety of ways, a variety of types of surveillance systems. There's laboratory-based surveillance systems too, where as a laboratory system is also may have to report in, like in the lab we've had X number of these positive results for a given disease to then help determine if there's an outbreak occurring. So as those systems get put in place, you will hopefully be able to catch an outbreak of significance through one or multiple of those systems. But in terms of who owns the data and sharing of the data, for us, in many countries, we do have data sharing agreements in place. That doesn't mean we can just take data and run with it. It means that we've got an agreement, and usually within the terms of those agreements are, specifically what you would have to do if you wanted to, analyze data and publish on data, and how the collaborative nature of that.
So I think we have time for one more question, and then we'll wrap it up.
Okay.
Seb, I was wondering about your thoughts on coordination, and then specifically two aspects. I've been fortunate enough to work with some CDC staff while I was working on Norway's contribution to the GHSA in areas in West Africa, and I was just curious about, depending on funding and what happens moving forward here. I've seen and benefited professionally from CDC staff on ground and seen how their personal, on a person level, their relationships with people on the ground has helped a different country who was a GHSA contributor, like Norway, as an example. So I'm curious about what your thoughts are on if some of those personnel have to come back, or they can't stay in country as long as they have before, thus changing maybe that dynamics of the personal relationships on ground that other people benefit from, not just the U.S. government but other governments as well. And then related to that is, if we are to involve more stakeholders, as in non-traditional stakeholders, moving forward, if there is a dry up of government funds, I'm curious about how we can what are the incentives behind more effective coordination? The truth is, you'll have people come in, it'll be an NGO or someone from industry or a government, and they'll run similar, let's say tabletop exercises with the same people, and then, 1 month this is completely hypothetical, but it's a European country, and then you have an Asian business come in the next month, and then you have. And so I'm just wondering about what your thoughts are on how we can sort of improve that coordination moving forward.
Yeah, that's a great question. So on the relationship side of things, I agree with you. And having been in country for a number of years, it really is very important to have strong relationships. So I think we still will be able to have relationships with those countries. We currently have relationships with a lot of countries where we're working collaboratively with them, but we don't have staff on the ground. We will always, also have our State Department there, our embassies there, and they can serve as a point of contact and can connect back to us as well. We talked earlier about our headquarters assets in terms of deployments, but we also have a wealth of individuals back in Atlanta across, experts in every disease that we might be dealing with, that could go and either virtually or in person kind of help and provide technical assistance, and not just in an outbreak kind of a setting. It's that ongoing, that's the importance of these relationships and the building of the systems, is that ongoing technical assistance, which I think can still be provided from a distance too. And we have other partners on the ground as well. USAID is on the partner in many of the countries and is working in certain components of the global health security agenda. And so I think for us as a U.S. government interagency, there's, whether it's us or it's USAID, there's always State Department, so we'll always have some members of those teams in different places, and it's just the importance of, as you said, the communication and the coordination, so that we can work effectively across all of our assets, whether they're CDC assets or other assets. Coordination at a country level of all of the different stakeholders and players is something that's always been a challenge, even in other public health programs that are happening. In all of the countries that I've worked in, we have had regular meetings of development partners or groups. Now, because I was working on the HIV side, a lot of that focused on HIV, but there are also coordination groups that are led by often the Ministry of Health or their arm that deals with donor coordination that will bring together all stakeholders. So I think utilizing those kinds of existing structures is really important, and making sure that as new stakeholders come in, that they find out about them, that they're informed about them, and that they know how they can then plug into those kinds of coordination systems.
Well, if you could please join me in thanking Dr. Knight for her time and for her fantastic work.